Thank you. Okay, my dear, I'm going to apply a drape to cover your eyelashes. I want you to open your eyes for me if you can. There you go. Now just look down towards your feet. There you go, just like that. Beautiful. I'm just covering these eyelashes, protecting your eye from bacteria. Perfect. You're doing great. There's going to be a bright light coming in front of you. It's very bright at first, but your eye will kind of get used to it, okay? Sorry about that brightness. Let me know if you have any discomfort. You may feel pressure, see shadows, colors, but you shouldn't have any pain, okay? Does that hurt or no?
No.
No, good. Numbing drops always sting, and this is some numbing solution. It may sting a little bit. Sorry about that. There we go. No pressure. Doing great. The cataract is like a grape. I'm tearing an opening in the front of the grape. Circular opening. Hydrodissection to separate the cataract from the capsule. This patient does have some astigmatism, however, the astigmatism on our measurements was inconsistent due to EBMD, or epithelial basement membrane disease. And so I didn't feel super confident with a toric lens, or because what if we put the toric lens and the astigmatism axis was off a little bit, or the magnitude? Light adjustable lens would have at least given some chance for the eye to heal and for us to take multiple measurements post-operatively. But this patient is not opposed to glasses, so although we're going to minimize them for far, we are going to be putting in a basic monofocal lens, the Aspire monofocal by Bausch & Lomb. It's a great lens, very good lens. Compared to the cataract, vision should be a lot better. Separating the cataract into multiple pieces. There's 2. Sometimes 3 pieces are enough, but usually do 4. There we go. All right. Pretty easy. Not too dense, which is great. Makes it easy. Protecting the capsule now. My second instrument. Just going to vacuum this one more posterior. There you go. IA and the lens.
Lens, please. Jeanette, lens, please. Cortex.
Yep.
Okay. B&L Aspire 23.5, sterility expiration 2027 for the left eye.
So we always double check the lens prior to opening it. Polishing. Just polishing this capsule. I'm going to flush it as well. Flushing decreases the need for capsulotomy, at least early in the postoperative time. I'm going to flush from the other angle. There's that strand there. It's loosened up. Good. Stable visc. Polisher. All right. I'll take the lens. So
Lens, B&L Aspire 23.5.
the polisher looks just like my Drysdale almost, so I can use it as the second instrument that I'm used to. A little pressure here, my dear. You're doing great. There's the Aspire lens going in. I got this right here. Polisher to put the lens in the bag. Perfect.
You want this to go?
Beautiful. Just making sure all the viscoelastic is out. VSS.
CSS.
Have nice overlap of the optic with the capsular excess. To hydrate my incisions. I usually hydrate a little bit on each side and then the roof. Now I have this subincisional strand I'm going to remove.
You're on cortex.
This subincisional. There. Okay. All right. Let's take the Moxie. You check my incisions first. Pressure's a little high. Good. That's watertight. Now, a little bit in there. Make sure the pressure is good. It's a little high. A little high. Doke. Kiss of Moxie. All right, cool. You, my dear, are all done. Little tape here. Sorry about the tape.
That's all right.
Is the tape harder than the surgery?
Yes,
right?
I think, I like the way you do it, talking,
Good,
yeah,
good,
because I was out of it
good.
last time.
Well, sometimes we give people sedation and they fall asleep. We don't put them to sleep, but they fall asleep. And sometimes we give them the same sedation and they're more alert. Most people are more alert with their second eye. Just happens to be the case, so
Yeah.
yeah. But you did great. So happy for you, okay?
Thank you.
Got it. My pleasure, dear.